Well, hello and welcome back. We are going to be talking about the digestive system um, and the disorders that can occur as well in that system, and then some of the medications that we're going to use to treat when things go wrong. The digestive system includes the gastrointestinal tract, okay, and the accessory muscles. So let's not forget about that. Things like the liver, the gallbladder, the exocrine pancreas, okay? All the things we need to basically um, ingest and digest food, right? Things that nourish our body. So we talk about the endocrine parts of the pancreas when we talk about the endocrine system, right? This would be the exocrine system that is part of the gastrointestinal system. So again, the hose, right, goes in here, comes out the other end, and all the stomach, the intestine. But we can't forget the other important parts, and that is our pancreas and our liver and gallbladder. Okay, so using most of our normal resources, our Nursing Central, ATI MedSurge, okay, that's where I'm getting this information for this lecture, as well as your ATI Farm and ATI Nutrition. All right, thanks so much. So let's look at the function of that digestive system. Remember, that digestive system includes the GI tract, the pancreas, the liver, and the gallbladder. And the GI system carries out at least, or I should say the digestive system, carries out at least four major functions. The digestion of food, very, very important, absorption of nutrients, which primarily happens in the small intestine. That's where a lot of those are absorbed, and secretion of hormones. That is from a lot from the pancreas for sure, and defense against pathogens. So, and of course, elimination of waste. So there's actually one extra there. The digestive system breaks down ingested food, prepares it for uptake by the body cells, right? Absorbs water and then eliminates that waste. The GI tract and gut microbiome, which is all that bacteria that's normally there, provide important immune and protective function. Except for chewing, swallowing, and defecation of solid waste, the movement of the digestive system is moved along by peristalsis. Okay, we're going to have some terms that you need to know, and this is going to be one of them, and are controlled by hormones and the autonomic nervous system, ANS, right? So that's really the system that controls the digestive system, is the autonomic nervous system that helps to move things along within this digestive system. Okay, so food breakdown begins in the mouth, we know that, with chewing, and continues to the stomach, where the food is mixed with acid, mucus, and enzymes. From the stomach, the fluid in the partially digested food passes into that small intestine, where bile and enzymes secreted by the intestinal cells, the liver, the gallbladder, and the pancreas break it down into absorbable components of protein, carbohydrates, and fats. Nothing too new here, right? The nutrients pass through the walls of the small intestine into the underlying blood and lymphatic vessels, which carries them to the liver for storage or further processing. Okay. Ingested substances and secretions not absorbed in the small intestine pass into the large intestine, where fluid continues to be absorbed. Fluid waste travel to the kidneys and are eliminated in the urine. Solid waste passed into the rectum and are eliminated from the body through the anus. Whew, crazy system. And when everything works well, everything goes well, but a lot of things can go wrong. So we're going to keep moving on, looking at the structure a little bit more, and then getting into some of the disorders that can occur. Okay, so accessory organs to the digestive system. Big one, the liver. Not going to talk too much about it, but need to know a few things, because as we get down further in this system, we're going to talk about GI bleeding, right? Sometimes things that can cause bleeding. Well, the liver serves a really big purpose in that, or can lead to that, can also lead to other problems like buildup of ammonia, buildup of fluids. So we're going to talk a little bit about the liver. But what does the liver do? It does a ton of things. The liver continually produces bile, which is the main thing that it does for the digestive system. It's a chemical that turns fats into energy that our body can use, right, for energy. So bile is necessary for the digestive process. Our liver also creates albumin. Albumin is a blood protein, right, that helps carry hormones and drugs and fatty acids throughout the body. Okay, so that's wonderful, but those same fatty acids, we rely on our liver to not only break those fatty acids down, but then help us get rid of the byproduct of that, which is ammonia. Okay, so ammonia is produced by the metabolism of amino acids. Okay, so our proteins, right? That's really what those building blocks of our proteins are, and other compounds that contain nitrogen. Okay, the liver converts ammonia into urea. Okay, that then is released in the blood, transported to the kidneys, and then filtered down and excreted out in our urine. But if we don't have a good liver, we could have high ammonia levels. High ammonia levels, we call that hepatic encephalopathy, okay? A buildup of ammonia is hepatic encephalopathy. So I've kind of skipped down there. What's it going to look like? It's going to look like confusion, altered level of consciousness, slurred speech, eventually coma and death. Okay, very bad. So what do we do for it? Lots of fluids, electrolytes, get them balanced out. And then lactulose, which is one of our laxative, our osmotic laxatives that we're going to talk about down in that section. But again, now we know what we're talking about when we talk about hepatic encephalopathy and some of the causes for high ammonia. Now, I'm going to head back up. So another problem that we can have is as the liver gets damaged in any way, or the blood flow through the veins get obstructed in any way, we could have what's called portal hypertension. So what can happen is instead of the blood, the big blood flow that comes through the liver, which over here on the left, take a look at that big vein, that big portal vein. As that starts to get obstructed because of disease of any sort, we have a shunting of blood. The blood gets shunted up the esophageal veins or the gastric veins, and they can get overstretched, and they could rupture, because look at the size of the portal vein compared to those esophageal and gastric veins, and we have that lots of new blood flow through there, and they can get big and overstretched, and then they can break. Now, we call those big overstretched veins varices. Okay, those varices can be in the esophageal veins or in the gastric veins, and they can rupture and cause massive GI bleeding. That would be one of our upper GI bleeds that we're going to talk about a little later. Okay, so portal hypertension, what is it? Obstruction of that portal vein causing shunting of the blood. What do we call those overstretched veins? Varices. Okay. When the liver starts to fail, we can have a buildup of ammonia, hepatic encephalopathy, confusion, and coma and death if we don't fix it. Okay, we're going to fix it with fluids and lactulose. Lactulose is a laxative that draws in that ammonia and then moves it out through the bowel. All right. So lastly, we also can have a collection of fluid as the liver starts to fail. Collection of fluid in the peritoneal space, and we call that ascites. okay? And that is usually seen at that end stage liver failure, okay? So just a few terms, a little bit about these things, because we're going to link these to other problems in the digestive system and the GI tract. All right, thank you. All right, so a little bit more about structure. Now remember, this is not a primary anatomy nor physiology class. So just a little review of this structure. So histologically, the GI tract consists of 4 layers, okay? From the inside out, they are the mucosa, all right? The submucosa, the muscularis, and the serosa or adventitia. So they're like these concentric layers. They vary in thickness, and each layer has sublayers. So neurons forming the enteric nervous system, the ENS, are located solely within the GI tract and are controlled by local and anatomic nervous system stimuli. So we have the enteric nervous system comprised of 3 nerve plexuses located in different layers of the GI wall. And they are the 3 together. Don't worry about each one, but the 3 together form the intramural plexus. And these muscle layers, these different layers, regulate the motility reflexes, motility meaning how things move through this, blood flow, absorption, secretion, and immune response. So they do a lot of different things. So again, little review of this. If you don't remember any of this, and that's not, that I think we have this in our patho book, probably a little bit, but maybe going back to your anatomy and physiology is going to be important. But just understanding the structure of this system, not moving backwards, but we're going to keep moving forward. So, a lot of structures within this system, right? The mouth, the esophagus, the abdominal cavity, stomach, small and large intestine, rectum, anus, right? All the way out the other. It's one tube, starts here and comes out the other end. It's pretty amazing. It's got all these muscles that move everything along within it. That's why when you could swallow something standing on your head, because it's not gravity that moves things through this system. It's this peristaltic movement that moves things along. So pretty amazing. But each system does something to get things in a form that can be absorbed, and then to absorb those nutrients as we go through. Once again, most of the nutrients are absorbed in the small intestine, and most water is removed in the large intestine. All right, and then waste fluid would go to the kidneys, and all the other solid waste would come out through the rectum and the anus. All right, so you can read this and then look this over, and then always using your patho book for further information as needed. You can open this right to our chapter, and all of this is right there. All right, so we're going to keep moving. So we also, part of our digestive system is these accessory organs. Our liver, gallbladder, and the exocrine pancreas all secrete substances necessary for digestion of the chyme. Chyme is that partially digested food that comes to the small intestine, right? After we've chewed it, it's come to the stomach, added the acid, and then it keeps moving on. But these secretions are delivered to the duodenum through the sphincter of Oddi at the major duodenal papilla, okay? So the liver produces bile, which contains salts necessary for fat digestion, right? We think about the liver and the gallbladder for that fat, right? Pancreas is both an endocrine, which I kind of hinted to earlier, endocrine, and which is responsible for insulin, but the exocrine organ responsible for secretion of digestive enzymes. Okay, so that's where we're going this time. Digestive enzymes as well as ions and water into the duodenum. So it serves a huge function in the digestion of nutrients. The exocrine pancreas produces enzymes needed for complete digestion of carbohydrates, proteins, and fats. It's amazing because really we think about the endocrine pancreas is really just those simple carbs, those sugars. An alkaline fluid that neutralizes chyme, creating a duodenal pH that supports enzymatic action. So all of that is that exocrine pancreas. So it does a lot of things. The liver also receives nutrients absorbed by the small intestine and metabolizes or synthesizes them into forms that can be absorbed by the body cells. It then releases those nutrients into the bloodstream or stores them for later use, right? And as glycogen, we know that. So these are all part of that digestive system, okay? Because we rely on not only the GI tract, but these other organs to complete the process. All right, so as I said, there's going to be some terms that we will need to know, and we're going to have others, but we gathered up a few so far. So let's run through some of these. So I've been using this term chyme, okay? CH is actually a K, chyme, which is a pulpy, acidic, partly digestive food that passes from the stomach to that small intestine, where the majority of the nutrients are absorbed, okay? Chyme, all right? Then we have our intestinal motility, which is the movement of the small intestine that facilitates digestion and absorption. Chyme leaving the stomach and entering that duodenum stimulates intestinal movements that help blend secretions from the liver, the gallbladder, the pancreas, and the intestinal glands. A churning motion brings the luminal content, all the stuff that's in the tube, right, in that GI tract, to those absorbing cells and the villi that help to absorb those nutrients. And all in time moving that to the large intestine, where it is then all that extra water, that fluid is pulled off of it, okay? The two movements that promote motility are segmentation and peristalsis, so two different movements that make up that motility, okay? Segmentation consists of localized rhythmic contractions of the circular smooth muscles and occur more frequently than peristalsis. Segmentation divides and mixes the chyme, bringing it into contact with that mucosal surface. It also helps to propel that chyme towards the large intestine. All these things are part of that motility to move things along. But intestinal peristalsis is waves of contractions that move down, along that longitudinal smooth muscle and propels the chyme through the intestine. So these two, segmentation, wah, 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 and the peristalsis is kind of a wave that moves through, moving this stuff through the intestine and then to the large intestine. Most of this happens in the small intestine. Now, when it doesn't move, we call that gastroparesis. It's delayed gastric emptying in the absence of mechanical gastric outlet obstruction. So we wouldn't say they have gastroparesis if there was an obstruction that was causing it. So mostly associated with diabetes mellitus, surgical, like maybe after a surgery, something like that. But it's when we don't have, so absence of motility, right? We would call that gastroparesis. Everything's slowing down, nothing is moving along, which means we don't get the nutrients either, right? We don't get that either. Now, when we talk about intestinal microbiome, we mean that gastrointestinal bacteria, right? We have this bacteria that is in our stomach and all through our GI tract. We actually talk about that with antibiotics. When we lose it, we then open ourselves up to secondary infections, which isn't good, right? So that's when we talk about what is biome, means that it's that good bacteria that's in our GI tract. All right, that's pretty much where you need to go with that. So again, some terms, we're going to be adding maybe some others on, but to be in conversation as we move forward, you need to know what we're talking about with these things. All right. So we're going to start getting into things when they start to go wrong, okay? Some things we're going to talk about just simply know what they are. Other things we're going to get a little deeper into, all right? But disorders of the gastrointestinal tract disrupt one or more of the structures and functions, right? The GI tract is a continuous, again, hollow tube starting here, coming out the other end, the anus, and things can go wrong in there. So we know that we can have a loss of appetite, right? Anorexia, a loss of desire to eat, despite a physiological stimuli that would normally produce hunger. That's what you need to know. There is lots of reasons, there's lots of problems, but in the end, we're not going to get the nutrients we need. So there's lots of things that we can do to figure that out. But we're not gonna talk too much more about that. Now we're going to talk a lot about nausea and vomiting. Okay, we know what that is. Nausea. I feel like I'm going to throw up, and then throwing up, a forceful emptying of the stomach content, right? Constipation, the other way. We can't get things to move along, right? So there is lots of non-pharmacological things that we're going to talk about for constipation, and diarrhea the other way. So either we can't go, constipation, or diarrhea, we're going too much, right? The shooty booty, right? And then just, again, abdominal pain, we assess, we look to see what the problem could be constipation, could be gastritis, an inflammation in the gastric lining, whatever that might be. But again, abdominal pain, we can't jump to one thing, right? It could be a million things. That's just a very general term, and we need to do a good pain assessment and then do some tests to follow up to find out what that is. All right, so we're going to get into some of these things. Again, abdominal pain, anorexia, just simply know what, some of the principles behind that. All right, so nausea and vomiting, it can be a big problem. Again, when someone vomits, we would say that's emesis. Okay, that's a term that you'll hear used. That's forceful emptying of the stomach content. And what is that content at that point? It's chyme, right? Because it's already been starting to break down. It's that pulpy, liquidy, right, in the stomach. Hasn't gone to the small intestine yet, right? So it hasn't gone to the large intestine, it hasn't gotten rid of any of the fluid, right? So we're just really chyme. That's what we're throwing up, okay? The vomit center is what we would call it, is in the postrema area of the medulla oblongata, okay, in the medulla. So we have, that is, if that center gets stimulated, we can have nausea and or vomiting, okay? So we can also have that sensation if we have a stimulation of our vestibular nerve in our middle ear. That would be that motion sickness that people experience. And again, that stimulation of the CTZ, which is the chemoreceptor trigger zone, or that vomit center, okay, in the medulla, all right? CTZ, chemoreceptor trigger zone, all right? So we can have that because of drugs or toxins sometimes. We can also have that sensation of nausea and potentially vomiting because of a stimulation or a release of dopamine and or serotonin. So when we start to look at our medications, we have both dopamine and serotonin antagonists. So we block that and we take down that sensation of wanting to vomit, basically. All right, so always looking at what causes, right, the disorder, and then how can we block that? And we do that with some of our medications. All right, so nausea and vomiting. Again, the medulla or the chemoreceptor trigger zone, the vomit center in the medulla, okay, or CTZ, or inner ear with that motion sickness that can also cause it. All right, so let's move on and look at some of our non-pharmacological things and things we're going to need to monitor for folks that are nausea, sure, but vomiting especially. So when we think about nausea and vomiting, we have to think about, we are getting rid of volume, right? So we need to make sure that we are always thinking and monitoring and replacing our fluids and electrolytes, right? And looking at things that will not further irritate the GI tract and soothe the stomach. So our weak tea, flat soda, keeping hydrated with gelatin, Pedialyte to replace not only fluids but electrolytes. Things that just are gonna soothe and not irritate. Crackers, dry toast, right? A brat diet, which would be bananas, rice, applesauce, not apples, but applesauce, and toast, right? So that's what we give to our little ones, our kids that are having an upset stomach. But fluids, and electrolytes, right? So our sports drinks, again, Pedialyte for our kids or anybody really, and sports drinks. Gatorade, I don't necessarily like the high fructose corn syrup, but some of our sports drinks that have that electrolytes in them, it's going to be our big piece. If we have somebody that's in the acute care setting, we would want to make sure that we monitor not only their fluids, their intake and their output, but their electrolytes, all right, to make sure that they're getting all of those. We will definitely cause potentially a metabolic alkalosis as we throw up all of that acid. And so hyperemesis, right, or hyperemesis gravidum during pregnancy is a real problem because it can cause not only electrolyte imbalance, but an alkalosis, right, an acid-base imbalance as well. Right, so again, so much of what we're going to do, we're going to talk about medications next, but keeping track of both fluids and electrolytes. So non-pharmacological, so important, but now we're going to look into some of those medications. Think about what causes us to feel nausea and potentially vomit, and then we're going to block some of those things off. All right, so let's move right into that. So many different categories of medications that can affect that feeling of nausea and then potential vomiting. We're going to break these down. So, but again, glucocorticoids, kind of interesting because we don't actually know the mechanism behind them, but they not only we know anti-inflammation, big piece of what they do, but they also serve as something that does potentially decrease that feeling of nausea and potential vomiting. And then lots of others, but let's go ahead and get in here and we are going to break these down a little bit. So here they are, a couple examples of our glucocorticoids that we would use for nausea and vomiting. Again, not quite understood how they work, but they do. Used for kind of high-level nausea and vomiting associated with chemotherapy, okay? We would give them IV short-term, and because they're just very short-term, minimal side effects, okay? So, but we know some of the side effects that we might have, and that would be that increased blood sugar. We don't want to normally stop really quickly because we could have some adrenal dysfunction, right, by cutting them off too quick. But otherwise, not quite sure how they work, but they do work. So just the way that ATI has this laid out, I actually wouldn't do it this way. They kind of look at some of the meds that they treat higher end nausea and vomiting. You know, higher end meaning like from post-op or chemotherapy. Cancer patients, they have pretty serious nausea and vomiting. But this is another one. This is blocking the serotonin. Remember that one of the things that can cause that feeling of nausea and then vomiting is that serotonin release. So this is blocking that serotonin and preventing that feeling of nausea and that vomiting. So blocking that serotonin receptors in that CTZ, right? That vomit center, and preventing that from happening. But again, this is that high-end vomiting associated with, again, chemotherapy and post-op, okay, from anesthesia. This can cause, again, not too often, but dizziness is probably the big thing. Ondansetron and ganacitron, so these serotonin blockers or antagonists. Headache, diarrhea, again, not usual, but dizziness is definitely one of those things that can we can see with patients that take this. Ondansetron can be pills. It can be a dissolve under the tongue, sublingual, which works very, very quickly and works very, very well. I've had a lot of practice with ondansetron while my son was on chemotherapy, and it works really well, but he definitely said that he had some dizziness with it for sure. Yeah. But good med, again, higher level. This is not just a little motion sickness or anything like that. This is pretty high-end vomiting from like chemotherapy. So another group of meds, remember another thing, when dopamine is released, it also can cause nausea and vomiting. So again, this is another higher level of vomiting, again, because of anesthesia, chemotherapy, radiation sickness, but we have some kind of higher end meds to treat that. Our dopamine antagonists, promethazine, phenothiazines, this is the group, phenothiazines, prochlorperazine. So promethazine is probably the more common one, but suppresses that emesis by blocking those dopamine receptors in the TCZ, okay? Definitely we can have some sedation that can make them feel a little bit drowsy. But the big thing is when we block dopamine, we can have extrapyramidal syndrome, which is what we see with some of our psychiatric drugs, and it would include things like pill rolling, where people have pill rolling tremors potentially, tardive dyskinesia, which is like a slurred speech. We can have anxiety, paranoia, lots of different things that can happen. Tongue thrusting, kind of this tongue thrusting, again, when we block dopamine. So we keep it, it's a lower dose than we would use for some of our psychiatric disorders. So we hope that there's not these extrapyramidal syndrome. We also can use antihistamines to help some of that EPS stuff that happens, but it is a side effect. All right, so when we block that dopamine. So another category of antiemetics is our cannabinoids. So dronabinol, I'm not sure actually how you say it. This is a very new one. This would be our non-intoxicating cannabinoid. CBD interacts with serotonin releasing receptors. So it alleviates nausea by basically blocking that serotonin and then preventing that feeling of nausea and preventing vomiting. But the nice thing with cannabinoids is that it also helps to stimulate appetite. So this is a good one to use for our folks that have cancer and AIDS. This is another one. Our AIDS patients that have vomiting, because it'll stimulate their appetite, and they need nutrients to help fight the fight of whether it's AIDS or cancer. So this is kind of a 2-for-1. But again, another category of antiemetics, and that is our cannabinoids. And actually ATI just identifies one, so that makes it a little easier. So another category of antiemetic is our prokinetic agent. And they actually only have one prototype in ATI, and that's our metoclopramide. Now, this does block dopamine and serotonin receptors in the CTC, the vomit center. But another thing that it does is it also promotes gastric motility. So it helps to empty the stomach quicker. So if something that you ate was irritating your stomach, this would be a good one. We also use it for treatment of GERD, which we're going to talk about in a little while. But again, it speeds up that motility. It does help that stomach to empty. So again, this is good. Another agent we can use for nausea, for sure. Because we are blocking dopamine and serotonin, we may see some of those extrapyramidal syndrome, that tongue thrusting, the pill rolling tremors, the tardive dyskinesia is that tongue thrusting, which we see commonly with our antipsychotic medications. Now, again, we give small dose of this, and we can take antihistamines to minimize that EPS. Okay, but another one, and we're going to talk about this one again when we talk about gastroesophageal reflux disease, GERD. Okay, so just one more medication that we can use for nausea and vomiting. Now, like I said, in ATI, they kind of run through this from like things we use for really bad vomiting, our chemotherapy patients, our AIDS patients, our post-anesthesia, nausea and vomiting. But now we're kind of getting into more of that motion sickness phase down at this end. And this one, scopolamine, which is one of our anticholinergics, again, blocking those acetylcholine receptors. So what type of side effects will this med have? It will have anticholinergic effects, right? The drying, the blurry vision, potentially urinary retention, and we don't give this to patients that have a history of glaucoma, okay? But scopolamine does decrease that stimulation of the vomit center and those vestibular pathways, meaning like in the ears, in those inner ears, so good for motion sickness. Now, scopolamine normally is in patch form. We put it behind the ears, little patches. You might see people wearing them, and they are just absorbed over very slowly over time. But again, our anticholinergics, one prototype that ATI does list is scopolamine, and again for more of our motion sickness. All right, anticholinergic effects. So, as I said, ATI kind of has these medications, some of the more serious nausea and vomiting down to some of our lower level nausea and vomiting that we may see from seasickness, from motion sickness, or even nausea during pregnancy. So our antihistamines, diphenhydramine, hydroxyzine, diphenhydramine, meclizine. These are over-the-counter medications like Bonine and I'm trying to think some of the other ones you can buy over-the-counter for motion sickness. But these are going to affect not only, again, the histamine receptors, but the acetylcholine receptors. So we're going to have those anticholinergic effects. So we don't want to ever encourage people that have a history of glaucoma to take these. If we are taking them for motion, we want to make sure that we encourage people to take them about 30 minutes before they travel. And we're going to educate and or monitor for urinary retention, constipation, making sure they have plenty of water while they're taking this. And these can cause drowsiness, remember. So they don't want to be operating that boat or that car, right? If they are, they have motion sickness and they're taking these medications, because it can make them drowsy. Not usually too bad, but again, not sure, always better to err on the side of caution. So we're moving on to constipation, the next fun topic to cover. So Constipation, what is it? It is a difficult or infrequent defecation, right? Having bowel movement. It is a common problem. It afflicts about 25% of the population in the US. And constipation means a decrease in the number of bowel movements per week, okay? Hard stools, straining, abdominal pain, and difficult evacuation. So it can mean a lot of different things. The definition of constipation must be individually determined because normal bowel habits range from 1 to 2 to 3 evacuations per day, or some people even just once or twice a week. So it really depends on the person. It's that change, right? That decrease, or all of a sudden it's very hard to evacuate, those kind of things. But causes can also range, could be because of insufficient water, right, intake, maybe poor dietary habits, that they don't have a lot of fiber, because we really need those fresh fruits and vegetables to keep things moving along, whole grains, all those kinds of things. And then, of course, we always worry about that getting so bad that people get impacted, they get obstructed, and then we really have some bad problems. Now, people that take laxatives will like chronically, can shut down the body's natural ability to keep things moving along. So overusing laxatives could cause people to have problems with constipation. Definitely neurological, spinal cord injuries, the same things that could cause neurogenic bladder can cause constipation as well, where they can't bear down to push things out. Bad habits as far as not listening to your body. When your body says to go, we need to go, or else your body will stop listening, and then you won't go. Exercise is a huge piece of this to keep everything moving along. So good walks, right? Exercising, moving the body is going to be a great thing. Good fluid, exercise, and a healthy diet. It's kind of the underlying key to a lot of these disorders. So our non-pharmacological treatments are going to be exactly that, right? Good diet, water, exercise, and then routine bowel habits, listening to your body when it says it needs to go. But when that fails, we do have some medications to help move that stuff along so that we don't end up with impaction, obstruction, all those higher level things that can happen. And they range from things that just basically bulk up, like a fiber laxative. We call that bulk forming laxative. A stool softener for people that it's hard and they really have to strain to push this out. To our medications like osmotic and stimulant, laxatives that clear, that watery, clear for a procedure, clear for a test, a colonoscopy, something like that. So we kind of have this spectrum of laxatives that maybe we take every day, and then others that we definitely won't want to take every day. Here it has, so frequent, or we have that purgative, like purge, just everything comes out, watery stool. So we're going to look at some of these and break them down a little bit. So our bulk forming laxative, these are things like methylcellulose and psyllium. This is a fiber-based laxative. Basically, it helps to absorb water from the intestine, increase the bulk, and then the peristalsis to move things along and out of the body. So these help to promote those good, healthy bowel movements that are not too hard, okay? So these we can take every day. We're gonna mix them with water or juice. We also have like fiber gummies that are very similar, also usually psyllium. They're but you chew them, but with those, lots of water. If we don't take these with enough water, we could cause an obstruction, so that's not good. But with these, we could see a little bit more gas, little cramping, but water really is the key to this, to hold off some of those side effects. Usually people take them with no problem. But again, bulk forming can be taken on a daily basis, especially for those people that can't get this good stuff in their diet. Okay, but lots of fluid, that's the key. So our next level is those stool softeners. Basically, this lowers things like docusate sodium. There is a docusate calcium as well, but it lowers the surface tension of the stool to allow it to just move out easier, basically, promoting water accumulation as well to soften up that stool, and will help prevent constipation. Again, these can be taken every day if you need it. We also use these as part of the treatment regimen for some of our more serious GI problems, like our folks that have diverticulitis or ulcerative colitis, spastic colon, maybe an obstruction so that things are soft and can move around it. During pregnancy, some people that have heart problems that they don't want to bear down to move a hard stool, so we will put them on these as well to help it just move out easier. Okay, so again, stool softener or a surfactant laxative, docusate sodium. All right. Now we're getting into a little bit more watery, evacuate everything from the bowel, maybe a prior to surgery or before a colonoscopy or a diagnostic test, something like that. We would not use these stimulant laxatives if we were concerned about a potential obstruction or fecal impaction, okay, because we could cause a rupture. All right, so we don't want to have anything that's going to stop this process from emptying out. Okay, so this would be part of usually this with our next one. We're going to talk about an osmotic or saline laxative together, like prior as part of a prep for surgery or a diagnostic test. But these will produce watery stool. They will produce, gotta run to the bathroom quick, some cramping, lots of fluids with these too, because you're going to be getting rid of lots of fluids. Okay, so we're going to be watching out. Can be irritating to the bowel, so we want to make sure that we watch out for GI bleeding. We're going to monitor fluid and electrolytes for these folks. It's probably a good idea for them to maybe supplement with a little electrolyte drink as well. It can kind of cause the urine to be a little reddish brown, so make sure we let them know that they're not bleeding, that this is most likely just an effect of this medication. All right, but usually, again, it might be a one-day prep. We don't normally keep people on these things for very long. Now, I take that back a little bit, because senna, sometimes we will mix senna with one of our stool softeners. So it might be a docusate sodium with senna, and the senna is a smaller amount. And sometimes we'll use that for our folks that have spinal cord injury, chronic problems where they can't move things along, where they actually need this stimulation all the time, but it's a smaller dose. So we don't see the watery stool, but just a constant kind of higher end laxative. So once in a while, and you'll see those mixed together, that softener with senna. Okay, so that's just one little caveat for that. All right, so we're going to break these osmotic or saline laxatives down a little bit. We kind of have to look at this as kind of three buckets. All right, we have lactulose and magnesium hydroxide. Great, both of them going to pull that salt and water into the colon, producing liquidy semiform stool. We can use these in a high or a low dose to depending on what the treatment we want. And then we have in our third bucket, we have polyethylene glycol, because we can't use these medications if someone has renal failure or heart failure. So because it shifts too much fluid, all right, it can be very hard on them. So I need you to know those two up top plus polyethylene glycol down bottom. Now, one other thing is we don't normally use lactulose as just a straight laxative. We're not normally using it as a laxative, although lactulose does draw saline into the, water into the intestine and does soften the stool. What it also does is draws ammonia in with that and sequesters that ammonia into the stool and moves that ammonia out of the body. For who? Who do we care about ammonia? We care about ammonia for our liver failure patients, our cirrhosis patients, liver cirrhosis. Okay, so really think about lactulose as definitely a laxative, but what are we doing? We're taking ammonia out of the body. All right, then we have our magnesium hydroxide for anybody else. Okay, and a good laxative to clear for procedures or surgeries. And then we have our polyethylene glycol for our renal and our heart patients. All right, so 3 different buckets here, all osmotic laxatives, and kind of how we use them and why we use them. All right, moving on. So these don't have a whole lot of information about pregnancy. Most of them don't cause too many problems. We have to be more careful about our higher end that empty out. But our stool softeners and our fiber laxatives, not usually a problem too much. But we are going to get some good history about diet, about laxative use, kind of getting to the bottom line of what is the underlying problem, right? And why do we need some of these laxatives? Making sure we look to see what other GI or intestinal disorders they have, like our ulcerative colitis, our Crohn's, our diverticulitis or losis. We're going to talk about those in just a few minutes. And also making sure that there's no chance of obstruction anywhere. So we might be doing ultrasounds and things like that. Getting a good history of how long it's been since they've had a bowel movement, what that bowel movement looked like, was it soft, was it hard, did they have to strain, all that stuff before we decide how we're going to treat this. And we'll always educate to and consider those non-pharmacological things as well. Changing the diet, getting exercise, talking to them about bowel habits before we start them on any of these medications. All right, let's look at some of that education that we're going to need to be concerned with our laxatives. All right, so again, big thing. We're going to educate to good dietary habits. People don't know what high fiber means. They don't understand the nutritional value of fruits and vegetables and whole grains and how important that is for us to have that healthy bowel. Okay, that's where that absorption happens of all of our nutrients. And fluids, lots of fluids. Fluids does not mean soda, right? Fluids means water. That's really what we mean, with maybe a little supplementation of a sports drink once in a while. Okay, so lots of fluids, good routine exercise, right? And good fruits, vegetables, and whole grains. All right. And then lastly, listening to our body. When our body says to go, we need to go, or else it's going to stop listening, right? The body will just say, well, I have the urge, nothing happens, and it'll shut down that, and people won't feel that urge anymore to go. All right. So regular exercise, regular good bowel habits. So just some basic things that we would think are very basic, but people don't always know. All right. What's normal, what's not, and those kind of things. So just having these, this education knowledge behind can really help people. Yeah, because this is can be a very serious thing. So now we're going to go the other way, talk a little bit about diarrhea. Okay, diarrhea can be from lots of different things. So diarrhea is the presence of loose, watery stool and may be acute, persistent, or chronic, right? Diarrhea is defined as the passage of 3 or more loose stools or liquid stools per day. Okay, that's usually not normal, okay? So, but we always want to establish what is normal for this person, right? This individual. Acute diarrhea is more than 3 stools, developing within 24 hours and lasting less than 14 days. So more than 14 days that's chronic, or at least persistent, moving to chronic, right? So then we really look for what's underlying here. All right, so lots of different causes: spoiled or spicy food, fecal impaction. So that's interesting. So we have this impaction of hard stool, and then we can have leakage of liquid stool around that appears to be diarrhea, but it's actually not. It's actually because of that obstruction. So we always have to be careful of that. Now, toxins or spoiled food. We go overseas, we eat food off of the street, and we can get an overabundance of toxin or bacteria. Usually it's E. coli, and we can have what's called traveler's diarrhea, right? Where we come back and, we have some little diarrhea. That should get better in just a few days. If it doesn't, or it is associated with a fever, we need antibiotics. That's the bottom line. Okay, so it should get better. We need to make sure that people have plenty of fluids once again, and some electrolytes, but it should get better. If it lasts more than 3 days and without getting better, and then or we start to have a fever, we need to get some antibiotics on board. All right, so we have, it can be because of an underlying problem as well, malabsorption or tumor or inflammation, right? Sometimes people say that they can get like an irritable bowel because of stress or anxiety, but again, that shouldn't be long lasting. So we can treat with those non-pharmacological measures, making sure that we replace those fluids, and then if we need pharmacological treatment, we're going to talk about them next. All right, let's move through. So it's all about decreasing that motility, right? Slowing down that movement of nutrients through the system. So what do we know about, well, let me just start with, so we have a couple. We have our diphenoxylate, and I'm going to talk about why would we put it with atropine. Atropine's a cholinergic. So we're going to talk about that. Loperamide, okay, and paregoric. All right, so we have some medications. These guys all have one thing in common, and that is that they're opiates. They're opiates. So when we talked about our pain medications, remember, one of the big things we worried about was constipation, because it slowed everything down. So now we're using that property to slow down the bowel. So let's talk about those a little bit. All right, so how do we slow down this shooty booty, right? That's the question. So we have some good medications, but what are they? They are opiates, right? We know that opiates decrease that intestinal motility. When we give an opioid for pain relief, right, we worry about that causing constipation. So we're using those properties to slow down the motility, right, to help with diarrhea. So we have things like diphenoxylate, loperamide, and paregoric. All right, so a couple examples there. Now, when we slow down the motility, we can have cramping, kind of upset stomach in the belly, and that cramping is really the big thing. So what do? We combine it with atropine, which is an anticholinergic, and we can take care of some of that cramping. All right, but with that, we're going to have those anticholinergic effects. Okay, we wouldn't want to use these for anybody that has glaucoma. We know that atropine dries things out, so that will help as well. But we always need to watch the other way, right? That we don't cause constipation. So again, a little bit of this to slow down that motility, hopefully figure out what the underlying problem is, and not take these long term. That's the bottom line. All right. A loperamide, again, slows down that motility. I think we talked about metoclopramide, which speeds up and empties. Loperamide slows down and holds things in. And then combining with the atropine for some of that cramping that we might see. All right. So because they are opioids, an opiate, we would want to be careful and monitor for CNS depression and respiratory depression. All right. So that's it. We're using that opiate effect to slow down and to help that diarrhea. All right. So other problems. Now, I'm going to kind of break this down a little. We're going to talk first about the obstruction, okay? And then we're going to separate the GERD and the hiatal hernia. But dysphagia, all you need to know about dysphagia, it's difficulty swallowing or the perception of obstruction while swallowing. That's it. We're not going to talk more about that. There's a million different reasons for dysphagia, but that is that difficulty or the perception of an obstruction when trying to swallow. All right, but let's look at some obstructions that we might see. Look a little bit deeper into that GERD and hiatal hernia. All right. So obstruction can be high, can be intestinal, small bowel, large bowel, anywhere along the system. But what you need to know is what it is. It prevents normal flow of chyme, right, through the intestinal lumen. Lots of different reasons. Can be stool obstruction, can be because of adhesions like scar tissue in the intestines, can be because somebody has a hernia. We're going to be talking about a hiatal hernia. Can be because other parts of the bowel comes through. What is a hernia? When part of the bowel, small intestine, large intestine, anything, comes through the muscle wall. Hiatal hernia is a little different where it comes through the diaphragm, but any type of herniation outside through the muscle can cause the bowel, the intestine to be obstructed, like that middle picture here, okay? Small bowel obstruction, normally things can't move through, so they come back up, all right? So we have vomiting is usually the first thing that we see, okay? Distension of the stomach, pain, right? And then that nausea and vomiting. But just understanding that upper, or I should say intestinal or small bowel can be because of this hernia, lower stool obstruction, those kinds of things. So again, just understanding that it's preventing that normal flow through the body. All right, let's take a quick look at hiatal hernia. Now, once again, hernia, general hernia is that small bowel, that intestine coming through the muscle wall on the outside of the body. And that's why we can usually see that protuberance on the outside of the body. Hiatal hernia, you can't see. Let's take a look at it. So hiatal hernia is a bulging of the stomach, right, through the diaphragm. So here we have some pictures of it here. And what's it going to feel like? Number one, it's going to, sometimes people say that they feel like they can't swallow. So there's that dysphagia. They'll have regurgitation because it can't get down into the stomach, or it's obstructed there. Heartburn, GI pain. What are we going to do? We're going to take down that GI pH with a proton pump inhibitor and potentially use some antacids. So that's what you need to know. We're going to talk about proton pump inhibitors and antacids taking down that acid content in the stomach. So when this does reflux, doesn't ulcerate the esophagus. But a lot of times we have this sliding hiatal hernia that it doesn't always cause problems, but it will slide up and then cause problems. And then we can have this rolling hiatal hernia where we have a large protuberance coming through. So they can get in there and repair the diaphragm to prevent this thing from continuing to herniate up into the thoracic cavity. Yeah. So again, proton pump inhibitors, there's some examples there, and some antacids. some examples there, so you'll need to know those. All right, let's move on. Don't need to know everything about it, just a little bit about what it is, what it would look like, and what we would do about it. So GERD, gastroesophageal reflux disease. So again, something is causing the content that's supposed to go down into the stomach to reflux, to backwash up into the esophagus. Well, unfortunately, when it backwashes up into the esophagus, it's got that gallbladder has excreted those very, very, very acidic enzymes to start breaking down the food. So the esophagus is not meant to have that acidity in that area. So we can have irritation, ulceration, severe pain. All right. So inflammation that occurs because of this, because of that reflux of gastric acid into the esophagus. Okay. So it can be because that sphincter at the bottom of the esophagus as it goes into the stomach isn't closing all the way, and it allows that backwash. Can be because people have big stomachs that are pushing up into that area, causing that not being able to close all the way. So smoking also tends to be an accelerant for this disease process. I actually can't speak to what that is, but it is one of the big factors that can cause GERD. So number one, what are we going to do non-pharmacologically? Stop smoking and lose weight. That's it. That's a big one. Smaller meals throughout the day. Don't eat right before they lay down. After they eat, make sure they sit up, right? Staying upright, allowing things to move through. Wearing loose clothing, non-restrictive clothing to allow things to not, have a lot of pressure on your diaphragm area. But how do we diagnose? So somebody comes in, oh, I'm having horrible pain. We rule out that it's not the heart, right? That they're not having angina. And then number two, tell me about this pain. Does it get better after you eat, or does it stay the same or get worse? Okay. With GERD, they'll say it stays the same or gets worse. All right. Very different when we talk about ulcers. After people eat, they will feel better. If it's an ulcer with GERD, it will feel same or worse. All right. So because the pain normally is right here in the chest, we will first rule out that it's not the heart, and then we will make sure that we ask them about the pain, and they will say, no, it doesn't get better after I eat. And we will think, might be GERD. Now, this is a medication that will help to empty sooner. Empty the abdomen, the belly, the stomach, to prevent it from coming back up, right? Metoclopramide, it promotes gastric motility and will promote gastric emptying, all right? So we talked about this, I believe, in constipation. Going to do the same thing. So we're going to empty quicker, all right? We also will want to take down the acidity in the stomach so that if it does reflux up, it just won't be as painful or as irritating to the esophagus. So those are our prozols, okay? You can remember the PP, the proton pump, prozol, so PPP, all right? So that's going to lower the acidity in the belly so that if it does reflux up, that we are going to not cause as much damage or pain. Again, going to reiterate the lifestyle changes. So we're going to eat small meals throughout the day, not big meals, okay? We're going to sit up after we eat. We're not going to smoke, right? We're going to lose weight, okay? We're going to wear nice loose clothes that don't restrict, all right? So we don't eat right before we go to bed. So just some really important lifestyle changes, as well as that diagnostic question we're going to ask them to get us to where we're saying it's GERD, and I'm going to give you some of these lifestyle changes and potentially some medicines, and hopefully they're going to be doing better. All right, let's talk about the next thing, where the pain does get better after they eat, and that is peptic ulcer disease. So peptic ulcer disease can happen, and ulcers can happen in lots of different places. Can happen up in the esophagus, again, because of GERD, down in the gastric area, in the belly, stomach, I should say, and or in the duodenum, right at the bottom of the stomach. All right. This is a gnawing, aching pain but it does get better after they eat. All right. So that's a little different. But there's a picture of an ulcer. Ooh, it just looks painful, doesn't it? It really looks painful. So let's take a look at a little bit more about peptic ulcers. So again, kind of where it can happen and a little bit about why it can happen. So again, esophageal, pretty straightforward, most likely because of GERD. Now, our gastric and our duodenal can be because of NSAIDs, maybe overuse of NSAIDs, but it can also be because of a bacteria. We call that bacteria Helicobacter pylori, H. pylori, Helicobacter pylori. So if we think it's an ulcer, pain gets better after I eat, we can do a breath test that will tell us if this is a bacteria, which is pretty cool. It's called a Mirtec breath test, and we can blow into this thing. Yes, it's H. pylori, and we'll know better how to treat them. We can also have stress ulcers. You will see every patient in ICU is automatically put on a proton pump inhibitor to take down the acid. When the body is in stress, it can cause a very acidic environment in the gut and can put people at higher risk for ulcers. So that we call those stress ulcers, and we do preventative measures when people are very sick to prevent them from happening. All right, so let's take a little bit more about how we treat if it is H. pylori, which I think it's around over 80% of ulcers are caused because of this bacteria. Okay, so let's look at that. So H. pylori is a gram-negative bacilli. It's a bacteria. And again, we can find out that, yes, in fact, this ulcer is because of H. pylori by a simple breath test. So it's pretty cool. We also can do a biopsy if needed. We really don't even do that so much anymore because we can find out if it is, in fact, this bacteria. It's a very resistant bacteria. So we put them on many antibiotics. Literature used to say 2 to 4. ATI says 2 to 3. But again, multiple. Why? To prevent resistance. Okay. But with this, it will eradicate over 90% of this bacteria. Okay. So we would give them this antibiotic, and then we would give them something to lower the acidity, either a histamine blocker or a proton pump inhibitor. Okay, ATI does give you both. I will tell you from practice, most of the time we just go right to the proton pump inhibitor. All right, so 2 to 3 antibiotics, long term, 14 days, and then something to lower the acidity. Treatment for ulcers. Okay, so these are some of the antibiotics that you will use to treat H. pylori, and then we're going to look at both histamine blockers and our proton pump inhibitors a little bit deeper. So our H2 blockers like ranitidine, cimetidine, famotidine, so these guys are going to block that histamine 2 and reduce that gastric acid secretion. Promote healing, right? By taking down the acid, promote healing of those ulcers. But I'll tell you once again, isn't quite as strong of a blocker as our proton pump inhibitor. So we just don't see these used quite as much. But we can see some side effects, usually very infrequent. But if anything, little constipation, dizziness, headache. Now, a little bit more serious, and again, we don't expect this, but we can see it. What is gynecomastia? Gynecomastia is when male patients grow breast tissue. We can see some blood dyscrasias at times. What does that mean? Changes in red, white platelets, okay, red and white cells. So we would be checking a CBC if they needed to stay on this long term. But this one also would be contraindicated or used with caution for liver and kidney patients. So we would be careful with that. We take a look to see what their underlying diagnoses are. Okay. This one will increase the effectiveness of anticoagulants, so we would probably look to put them on a lower dose of their anticoagulant. And over time, we could see B12 deficiency, so we would want to make sure we monitor that as well. All right. So, but otherwise does lower the pH to help that ulcer heal. Okay. Once again, standard treatment for ulcers is going to be the antibiotic and a proton pump inhibitor. I did bring in the H2 blockers just because ATI has them, but our Prozols is going to be the way to go. And here, literature does say it does inhibit the gastric secretions up to 90% greater than those H2 blockers. So normally we'll go right to these. Okay. Again, not too bad side effects. We do want to be careful with to look at those underlying disorders, the liver, especially looking at the kidneys always with any medications, and interactions with other medications. Usually not too much of a problem with most of our medications. But again, when we're looking at an ulcer, we want to get it taken care of. Now, we have one more that we are going to take a look at for ulcers. It's kind of a neat thing. It kind of forms a patch over the ulcer, and let's take a look at that medication. This is pretty cool. It's called a mucosal protectant. Sucralfate, okay, is the name of the medication, and it's really neat. It actually combines with the proteins in the stomach, and it forms this thick paste. And the normal mucosa that's not damaged, it just slips right off. But this roughened area where the ulcer is, it just kind of sticks to it. So what we do is we take it right before meals, about 30 minutes before meals, allow it to get in there, churn up, and stick onto the ulcer. And then when we eat, that acid, that increased acid in the stomach, can't touch that ulcer. Now, but the problem is that it truly is like paste, and it doesn't get absorbed in the system. So it comes out the other end like paste, like chalk. So we need to make sure we encourage plenty of fluids to prevent constipation. All right. So we can see a little bit of increase in blood sugar with this, little bit of hyperphosphatemia. We use with caution. We're going to check our BO and creatinine with this to make sure everything's okay with that. And of course, with our diabetic patients, we're going to have them check their blood sugar a little more often. Now, again, this treatment, they could be on this for up to 6 weeks, 8 weeks. We want the ulcer to be totally healed. Doesn't mean we come off of everything when the pain goes away. No, we know that ulcer is still healing. So usually they'll be on this for quite a few weeks. So again, we do need to monitor them for these things. Get some blood work, check their kidney function, of course their liver function with all medications, monitoring those electrolytes, calcium, phosphorus, right? And we need to make sure that they're okay. And yeah, so again, just a few things, but usually not that big of a deal with this, but kind of a nice patch for that ulcer so that it can heal in that acidic environment. All right, moving on. So these are our antacids. A lot of these are over the counter, our Maalox, our Mylanta, our Tums, our Rolaids, Alka-Seltzer. So those kinds of things to just take down the acid again in the stomach. We always make sure that we take these 1 hour before and 1 hour or 1 hour after taking medicines, because they can block the absorption of medications. Always, always, always. But it's going to neutralize that, neutralize the stomach acid. All right. So good for our peptic ulcers, our GERD, stress ulcers, but we are going to monitor our electrolytes. We're going to monitor our stool in, out, make sure that there's no diarrhea or constipation, monitor our kidney and liver function, our calcium, So kind of have it broken down there, because these are calcium, magnesium, aluminum, sodium, right? All those things that if we are supplementing can cause an imbalance the other way. All right, so nothing major with these guys. These just take down the acid, and they are mineral based or electrolyte based or vitamin based, whatever that, or mineral really, for the most part. All right, so nothing major with those. Just know a few names, kind of what they do, and some of the things that we would monitor for. All right, so we have one more anti-ulcer drug. So this guy has actually been in the news a little bit, misoprostol. So we know that it's a prostaglandin E analog, suppresses gastric secretion, and can cause moderate decrease in pepsin secretion. But what's it doing? It's protecting the GI mucosa. So for folks that have to take long-term anti-inflammatories to prevent that breakdown of the mucosa. But this has been in the news a bit because it's one of the medications that can be used for, what is it called? Day after drug. So it can cause spontaneous abortion. So we always make sure before we have to, maybe, again, folks that have to take this have some chronic inflammatory process that they're taking anti-inflammatories for. So again, we would hopefully know their history pretty well. We would make sure that they are not possibly pregnant or want to get pregnant while they're on this, right? Because it could cause spontaneous abortion. So again, when we see it in the news, this was a repurposed drug. This is what it was made for, okay, to protect the GI mucosa, but we found that it does this other thing, right? So it's kind of one of those things. It was created for good and then now created for other things. Yeah. So anyway, misoprostol to protect that GI mucosa for those that have to take medications that can irritate and cause ulceration. So nonsteroidal anti-inflammatories, our NSAIDs, our glucocorticoids, right? They also can do that too. All right. So let's look at some non-pharmacological treatments and measures that we would put in place for our GERD and our peptic ulcer patients. So let's look at some of those things, those non-pharmacological things, because that's always going to be important with any disorder that we can put in place for these folks with peptic ulcer disease and GERD, right? Gastroesophageal reflux disease. So both of them can be worsened by tobacco and alcohol. So we're going to just tell them to avoid it, you know. Weight loss, right? Avoid other things that cause irritation to the GI tract. That would be our hot foods, spicy foods, greasy foods, right? If they have to take NSAIDs, take it with food, right? Use those antacids as needed, 1 hour before, 1 hour after, okay? Sit up after meals, right? Smaller meals, don't eat before bedtime, wear those loose clothing, plenty of fluids, right? Keep everything moving along, and take the medicines as needed, all right? So for our folks that have to take antibiotics, we have one more thing that we would want to talk to them about. And that would be potentially replacing, right, that good bacteria in the GI tract, right? So probiotics would include acidophilus, lactobacillus, bifidobacterium. So a couple different kinds. This is our good bacteria, right? That when we take antibiotics, we can decrease, right? We can decrease that good bacteria and open ourselves to further infection, secondary infections, right? It also has been shown to support lots of different things, healthy weight, GI gas, diarrhea, bloating, all those things, leaky gut, lots of different things. So they're just a good supplement for people that have GI problems or are taking antibiotic. Easy to take probiotics, all right? but just thinking about that's that good bacteria that normally lives in our gut. All right. So just a couple other disorders that do need to be mentioned. Number one, irritable bowel syndrome. So irritable bowel is a functional condition. There is no pathology behind it, okay? It is a bunch of symptoms, so currently considered a disorder of a brain-gut interaction, right? Or functional disorder, characterized by recurrent abdominal pain with altered bowel habits. Some people have diarrhea, some people have constipation. So that's kind of interesting that the symptoms can be that varied. It afflicts about 10 to 12% of adults in the US. There is actually no known cause, and there's no specific biomarkers for this disease. So what do? We tell them some lifestyle things. So causes here, I have a little chart here. Definitely can be increased with stress or anxiety and even depression. It can be triggered by a change in the microbiome. So they had another disorder, maybe they had to take antibiotics, right? And we do see it from mother to daughter and so on. So is it genetics? Where it's no biomarkers, that's kind of a tough one. But again, not really sure. But we can see constipation and or diarrhea, abdominal pain, gas, bloating, okay? And treatment's going to be number one, lifestyle. So avoid those triggers, getting regular exercise, plenty of fluids, a good healthy diet with fresh fruits and vegetables and whole grains, all that stuff that keeps your gut really healthy. And then we do have some medications. So we have selective 5-HT3 receptor antagonist for IBS with diarrhea and IBS with constipation. We have a lubiprostone, okay? So don't need to know too much about these guys, but basically they're going to treat this disorder. That's what you need to know. You need to know the name, what we would treat it for. That's where we need to go. Not too much with this. Let's move on. So unlike IBS, IBD, inflammatory bowel disease, is definitely pathologic in nature. IBD causes an inflammation of the intestinal mucosa, which causes episodical abdominal pain, diarrhea, bloody stools, weight loss. And inflammation and ulcerations are caused by an influx of the neutrophils and the macrophage that produce that pro-inflammatory cytokines, free radicals. So this is a big process. So environmental factors that and infections are thought to alter the barrier function of the mucosal epithelium, leading to loss of immune tolerance to normal intestinal antigens. So those things that normally protect the gut no longer are good protection. So there can be triggers for these diseases, including diet, stress, viruses, smoking. Smoking for our Crohn's, not so much for our ulcerative colitis. So again, separating them a little bit, just knowing a little bit about them. So ulcerative colitis, ulcers in the rectum and sigmoid colon. And again, maybe genetics in nature, but not totally clear. Crohn's, inflammation anywhere along the GI tract, definitely higher risk for with folks that smoke and poor diet, basically, and for folks that take NSAIDs. So down bottom, nice chart, just differentiating these two. So just need to speak to this just a little bit, nothing major, all right? Okay. So IBD, just need you to know a few of these medications. Actually, some of them may look familiar from rheumatoid arthritis. Those ones we call DMARDs, remember? Disease-modifying anti-rheumatic drugs. But infliximab is one of them. And we definitely use glucocorticoids for the anti-inflammation. If we have inflammation for too long or breaking down of the mucosa, we can get infection. And we have our antibiotics. Metronidazole is going to be what we would use for that. So I just need you to know a few of these medications, that these are drugs used for IBD. Big, bad, nasty diseases of the bowel, and some of the things to take down inflammation. That's what we're doing with these. All right. We're going to administer these with food and encourage plenty of fluids. Most of these should be controlled release if they can be, because they're very irritating to the stomach. And again, don't need you to know much more than that. Just be familiar with some of these meds as they are attached to treating our inflammatory bowel diseases, including Crohn's and ulcerative colitis. All right, so that's where I need you to go with that. So lastly, I need you to know, just again, being conversation, what is diverticula, what is diverticulitis, or losis, and litis. So diverticula are herniations or sac-like outpouchings of the mucosa and the submucosa through the muscle layers, usually in the sigmoid colon, and they are more common in older adults. You see those little pocking kind of pouches that are in there, again in the colon. Diverticulosis is the asymptomatic diverticular disease, and diverticulitis presents inflammation of the diverticula and occurs in approximately 10 to 15% of cases of diverticular disease of the colon. All right, so they can have diverticulosis, meaning they have those pockets, but they don't get inflamed. Diverticulosis. Okay, so diverticulitis is when they get inflamed. Okay, the cause of diverticular disease is unknown, but it's associated with increased intercolonic pressure, abnormal neuromuscular function, and alteration in intestinal motility. Okay, it can have predisposing factors including age, genetics, obesity, smoking, diet, lack of physical activity, medications including NSAIDs, glucocorticoids, the very things that we may treat to take down the inflammation, could cause this irritation and these pouchings. Okay, we definitely want these folks to have good bacteria in that area to protect those areas that are open. So probiotics for sure in these folks. And we're going to talk a little bit more about nutritional. So we really don't do too much except for maybe some anti-inflammatories and antibiotics as needed for these folks, but we definitely do lifestyle changes, and that's what we're going to talk about next. All right, so let's finish it up with this one more slide about GI nutritional considerations, especially for our diverticulosis and our inflammatory bowel disorders. Okay, so let's finish this up. So much of the diverticulosis is about lifestyle changes. We don't want things to get caught in those pouches, right? So losis, meaning that we have those pouches, but they're not inflamed, and that's how we want to keep them. So we would recommend a high fiber, low fat diet, no nuts, no seeds, nothing that can get stuck in those pouches and cause irritation. Once they get irritated, we may need to do antibiotics so that inflammation doesn't lead to infection. Definitely pain medications, maybe an anti-inflammatory, maybe a steroid, right, a glucocorticoid. And we would do a bowel rest. We would put no food through that bowel. So a clear liquid diet. All right. Now, our inflammatory bowel diseases, it's kind of a weird diet, but Crohn's, ulcerative colitis, Low residue diet. What does that mean? Low residue diet means things that are low in fiber, which is weird, like white bread, white pasta, white rice, crackers, like saltine crackers, refined cereal, like puffed rice or corn, and then skinless potatoes. Sounds very unhealthy, but low residue. And then on top of that, high protein, high calorie. Well, a low residue diet actually is quite high in calories, but we want to make sure we can match that with some good protein. We also would do some pretty major vitamin and mineral supplements, especially with this diet, right? Making sure that we keep an eye on the fluid and electrolyte balance. We may need to give supplemental feeding for them if they're having an inflammatory bout. We might need to go to parenteral through the IV feeding, or even do a enteral feeding that we would be able to manage exactly what they put in their body. So again, it gets a little trickier. These are much more serious diseases. And we start with diet for sure, lifestyle changes for both of these. And then really our goal of treatment for our medications is anti-inflammation for the most part. All right. Whew, I know that was a lot, but we are through it. Don't get too deep. Take what I've given you, okay? Get a good understanding of it. If all I need you to know is basically what it is and some of the names of the treatments, like I've said on some of these slides, that's what you need to know, all right? You may be asked to know a little more from ATI for the pharmacological test, but again, for us, for our purposes, this is going to be a big exam with 3 big topics. I need you to know the foundational stuff, all right? All right, thank you so much.